So, good afternoon, everyone. The last but not the least session for this meeting. So the VT session, and I will let Larry to introduce all the speakers and the panelists.
Thank you very much, Mandine. So welcome, everybody. It's been a fantastic meeting so far, and this, I think, is going to be one of the best parts of it. This is a joint session between the Canadian Heart Rhythm Society, the European Heart Rhythm Association, and the Asia Pacific Heart Rhythm Society. So we have representatives and speakers from all of those groups. First, I'm going to do my co-chair, Kyoko Soejima. Sorry, I had it working in practice, from Japan. And then online, we have Helmut Perrer-Fellner, who's possibly in the only other place as beautiful as Banff right now, as he's in Austria, so joining us virtually.
Hi, it's a pleasure.
Thanks, Helmut. And then our discussants, we have John Sapp from Halifax and Isabelle No from Quebec. So again, this will be the panelists for discussions, but for the first introduction, I'm going to pass it over to Isabelle.
Thank you, Larry. So it's my pleasure to introduce our first speaker, Dr. Alexios Edgis. Dr. Edgis is clinical EP in Sacré-Cœur Hospital in Montreal. He has done EP fellowship in University of California in San Francisco and pursued additional VT training in Milan with Dr. Della Bella. So Alexios is going to talk to us about mapping VT in 3D.
Thank you very much, Dr. No, and I'd like to thank the Planning Committee for the invitation to speak with you all today about mapping VT in 3D, and in particular targeting the diastolic pathway. These are my disclosures. So, 3 issues that I hope to address with you today. Number 1 is mapping VT, where are we at? Number 2, why map the diastolic pathway? And thirdly, of course, the most important is how can we do better? To begin, substrate mapping has clearly made significant advancements, moving from primarily bipolar voltage mapping to more of an integrated functional substrate mapping that address not only late potentials, but we're looking at zones of deceleration. We try to identify rotational activation patterns. We may also use alternate techniques such as V-sense protocols or decrement-evoked potential mapping. In doing so, all of this has allowed for a more precise ablation strategy, targeting these same zones. And in fact, high-density remapping allows us to establish electrical silence, which at certain points and in certain cases can be used as an endpoint. High-density activation mapping, certainly more recent studies have provided new insights into this very complex circuit geometry. The ability that we now have to identify very low amplitude near-field signals rapidly and accurately has allowed us to visualize truly the dynamic nature of the VT isthmus. We know, in fact, that VT isthmus boundaries certainly may be composed of fixed lines of block, but there may be a functional line of block that not only depends on the isthmus, but in fact depends on the outer loop, its length, and their relative velocity proportions. As another example of the dynamic nature of the VT isthmus, we described a case of an incessant bimorphic VT storm, where not only did we demonstrate alternate exits utilizing a common isthmus, but in fact, we were able to demonstrate an alternate functional block within that same isthmus during the case. So just to give you an idea that the isthmus is in fact dynamic, and it's a 3-dimensional aspect. And these functional barriers that I've described are not always present during sinus rhythm, and in fact, it highlights somewhat some of the limitations of substrate-based mapping if performed during sinus rhythm or slow pacing rates. So the question that we often ask ourselves is to map or not to map? And this is the question that we wanted to answer. So in fact, we enrolled consecutive patients undergoing VT ablation who were categorized as either full diastolic map, meaning they recorded electrical activity in all 3 segments of diastole, bridging one QRS to the next, or as partial diastolic map, meaning they recorded electrical activity in only one of the 3 segments, or as substrate modification, meaning there was no electrical activity recorded in the diastolic interval despite adequate activation mapping time. All of these patients had more than 30 seconds of mapping. This is an example of our case flow. So on the top left, you have our ILAM map with a clear zone of isochronal crowding inferiorly. Right next to that, you have our fellow, Dr. Forel, performing the mapping. Now, so clearly here we've induced VT. Now, the goal is not just to record diastolic signals. The goal is to move your catheter in a manner that defines the functional reentrant pathway in, number 1, a timely manner, and number 2, in a manner that delineates the length, the width, and the extent of the reentry, as you can see here, as it's going up a little bit further away from that deceleration zone up the septum. Once mapped, we follow the same ablation strategy every time. So this is another case, ILAM map on the bottom right corner, with another zone of isochronal crowding. Up above on the top right corner, we have our VT activation map where we've delineated the diastolic corridor, purple being the outer loop, yellow being the isthmus. And again, the ablation strategy is to deliver contiguous lesions to organize a transecting line at the narrowest point between the boundaries of the VT channel. I'll try to. So really, we want to cut across here. And as we come on ablation, we have immediate termination within a few seconds, which is very satisfying. In this case, we ablated during VT. It doesn't have to be that if it's not hemodynamically tolerated. Obviously, you can ablate in a sinus rhythm or paced rhythm, but we utilize the VT activation map as our reference to deliver our ablation lesions. Once that transecting line is complete, we then target all areas that were operational during the VT. So entrance, exit as well. So here we have the voltage map, should be the activation map, but nonetheless we've delineated a little bit all areas that were operational during the VT. And you can see down below in the left corner, once the majority of the work is done, while we're still ablating, we'll do our programmed extra stimulation down to four extra stims to ensure that there's no inducible VT. The work is not done there. Oh, jeez, sorry about that. There we go. Sorry about that, guys. So even after the programmed extra stimulation down to 4 extra stims, no inducible VT, we go back and remap all areas that were operational during the VT to ensure that there is no near-field signal present in that area that we targeted. So we always have to confirm with a remap following. The reason for all of this, so what we showed, the end result showed us that recording of the full diastolic pathway followed by linear ablation at its narrowest site was actually associated with a higher freedom from VT recurrence. So 88% freedom from VT at 18 months. Interestingly, this was followed by quite a steep drop-off in those who only had partial diastolic activity or who underwent substrate modification. So why the drop-off? And I think this speaks to the three-dimensional nature of the VT circuit. So of course, how can we improve? Well, we can improve by looking in 3D. So simultaneous endo-epicardial mapping has already been described in surgical cases in human patients and also in ex vivo studies using a intramural multi-electrode plunge needle. Predominant intramural activation was imputed by the absence of significant diastolic activity in the endo and or epi, or it was derived by direct recordings of the intramural needle. And it was clear that a significant portion of VT circuits were presumed to be intramural due to incomplete diastolic activation in the endocardium and epicardium, which is, quite frankly, consistent with the findings of our study with a 50% freedom from VT in the partial diastolic group. As such, we described a technique for simultaneous endo-epicardial mapping that can reliably detect the presence of activation bridges in a 3D model of VT. So this is a case where, so on the bottom right, you have two multipolar mapping catheters, one endocardial, in this case via transeptal access, the other by epicardial. And you can see that we've essentially sandwiched that layer of interest where we want to record our VT. And given the nature of VT activation mapping, where hemodynamic intolerance can necessitate very rapid mapping times, the ability to simultaneously map both endo and epi and subsequently pinpoint the critical intramural location of the VT, imputed by the absence of significant endo-epi activation, it becomes key. Here is another case that, that we did, utilizing instead of, we just used a duodecapolar catheter in the endocardial surface and the multipolar mapping catheter in the epicardium directly opposed to map our VT. Despite being able to identify these critical mid-myocardial sites, sequential unipolar ablation may not, in fact, be enough. We know that in standard unipolar ablation, the depth of lesion is often 6 to 8 millimeters. So despite sequential ablation, we were lacking in terms of success, which led us to look at alternative options, including bipolar ablation. Bipolar ablation is not new. This is fairly straightforward. However, different applications may be utilized. Bipolar RF for intraseptal VTs is well described and can be quite useful clinically. We know that it allows for larger lesions and increased success rates for intramural arrhythmias. Endoepicardial bipolar ablation has also been described in a few case reports and a small case series out of Poland. The question is, however, what are the optimal parameters and potential limitations of this method? This includes type of electrodes, range of tissue thickness, optimal power, duration, orientation, and these are questions that we sought to answer. In these are in vivo experiments using porcine hearts. We performed bipolar RF between a 3.5 millimeter ablation catheter positioned in the LV endocardium and an 8 millimeter return catheter positioned directly opposite in the epicardial space. We're using, for all ablations, we're using a perpendicular parallel orientation. And each return catheter was connected to a generator using a custom-made cable. We are in the process right now of evaluating not only lesion transmurality, but safety. This is not a benign process. Fatal complications of endo-epi bipolar have been reported in animal literature, so clearly it needs to be studied carefully. Nonetheless, utilizing set ablation settings applied for pre-specified durations, we hope to answer the question as to how to effectively and safely achieve transmural lesions reproducibly. So to conclude, mapping VT, I think we've made many advancements, and I think we're on the cusp of having a profound understanding of the complex circuitry of the VT circuit. Why map the diastolic pathway? Because capturing it in its entirety can result in better outcomes. And how can we do better? I think by looking 3D to capture 100% of the circuitry to guide targeted ablation to the layer of interest. Thank you very much.
Okay, we started a little late, but we may have time for one or two questions or comments. Anything from the panel?
Thank you, Alexios. I'm very impressed that you can use 2 HD grids catheter for one case. We don't have the same administrators.
My fellow is in the audience. He loves when we do these cases.
My question would be, sometimes we have, as you showed, we have several different morphologies of VT. Do you find in those patients with all of those different morphologies, that the site of interest where you ablate is still within the same restricted area of your diastolic path, of your late activation map, or do you find several of these areas around the LV?
Yeah, it's a very good question. I think, so we certainly place our catheter in the zone of deceleration, not necessarily the latest point of activation during sinus rhythm. We often have different morphology VTs, but I think what's coming out now, well, number one, it's known that like the same circuit can produce different VT morphologies, and we often find that same critical area does correspond to multiple VTs with separate exits, as we demonstrated on that previous manuscript. So I often find that targeting that critical area, highlighting the diastolic pathway, often will eliminate multiple VTs.
Thank you.
Helmut.
My question is, how about half-normal saline? Do we use that?
We have indeed. All of our ablations are done at 50 watts. That's endo and epicardial, and that's a nominal setting for us. I have used half-normal saline, but I find the results a bit lacking. Obviously, it's not. I haven't looked at it, prospectively as a study, but I find I'm still not able to achieve the lesion depth desired, even with half NS and 50 watts.
We have experience in both the bipolar ablation settings with Piotr Futima from Poland, who was quite many times with us, and we learned a lot from him. Using the half normal, I normally tend to take 35 to 40 watts, but then cook the steak longer, so around 90 seconds to 2 minutes. And that's how it works. And if you have that and try not to give too much of energy, then you can avoid some bumping and some impedance risings. And I have to say I have good experience using half normal saline in this. Just to add something from my side.
Great. All right. Thank you very much.
I am delighted to introduce Kyoko Sojima. We're on?
Yep. Should be on.
You guys can hear me? Yeah. I'm really pleased to introduce my young friend for a long time, not my old friend.
That's sure.
Kyoko is visiting us from Japan as our special guest. And I met her when we were both at Brigham. She was a year ahead of me, and then she was my boss when she was on faculty there. She stayed for a little while, enough to be promoted, which is a big deal at Harvard, before going back to Japan. And she's now at Kyorin University, where she is the chief of cardiology and a renowned thinker and speaker, especially about ventricular tachycardia. She's going to talk to us today about whether catheter ablation should be first line for VT. Kyoko, thank you.
Thank you very much, Dr. Sapp. It's a great honor to be here, and I'd like to thank the Society for inviting me. It's such a great place, and it's always nice to getting in contact with the people I knew a long time. Land acknowledgement, and this is my disclosure. So I think today I'd like to talk about the VT management and mainly antiarrhythmic agent versus catheter ablation. So we know the VT associated with structural heart disease is majority of the mechanism is reentry and scar-related reentry. And 29% of patients who receives an ICD have VT treated with ATP or shock during the follow-up of 2 and 4 years. This is reported by Partita study by Dr. Della Bella. And a catheter ablation is an important therapy for reducing recurrent VT. But as you can see here, some of the reentry circuit locate in the mid-myocardium, and even like 2-minute ablation or half-saline ablation or bipolar ablation, sometimes it's very, very difficult to approach. So ESC guideline for the management of electrical storm list the sedation, as the class 1 indication, and also antiarrhythmic therapy with beta blocker in addition to amiodarone as a class 1, and also the catheter ablation, which is listed here, recommended in patient presenting with incessant VT or electrical storm, refractory to antiarrhythmic agent. So I think 3 major treatment for the ventricular tachycardia include antiarrhythmic drugs, mainly for the structural heart diseases, class 3 amiodarone, and a catheter ablation, and ICD. But not limited to this, because I think we do a lot of autonomic nervous modulation and also psychotherapy for the patient. A lot of new therapies coming up. So I'd like to share with you this very shocking picture of ICD. This is a picture of the explanted ICD from a patient who was on the transplant list for a long time. The patient received so many shocks for the VT and also inappropriate shocks for the atrial fibrillation. So after he received a new heart, he took the ICD back to his home and shot with a rifle. I thought this is very American because I never seen this. So this is entry point and this is exit point. But I think this picture I always show to my fellows, like who's gonna start a device implant. They consider this is just a day procedure, but for the patient, this is like ongoing lifetime therapy. So we always have to remember, like having a shock causes such an impact to the patient. So we have to do anything to prevent the patient having a lot of impact. So what about the VT ablation? So this is taken from the study comparing the peri-procedural complication rate in VT ablation. As I highlight here, if the patient doesn't have structural heart disease, the complication rate is relatively low. But if the patient has structural heart disease, it goes up almost 3 times. And if you do a lot of ablation, like probably the RV has a least complication rate, but if you go LV, antegrade, retrograde, and also epicardial ablation, the risk goes up. So we have to be aware of that. What about the intra-hospital mortality related with VT ablation? Again, if the patient has structural heart disease, it's higher. And also, if you do a complex ablation, multiple chambers and multiple surfaces mapped, it's going to be higher. So we always like to evaluate the patient prior to the procedure, nicely proposed by University of Penn. It's a PAINEST score. What they evaluate is if the patient has pulmonary disease or age higher than 60 years or ischemic cardiomyopathy, NYHA class 3 or 4, and ejection fraction less than 25% or VT storm and diabetes mellitus. So the higher the number, the risk for the in-hospital mortality is higher. The same group looked into the acute hemodynamic decompensation using the same score. And as you can see here, the score, the total number of the score, 15 or higher, acute hemodynamic compensation rate is 24%. It's quite high. And also if the patient has developed acute hemodynamic decompensation, in-hospital mortality is really high compared to a patient who doesn't have decompensation. So I really like to tune up the patient prior to the procedure because we want to have the very safe procedure. And I'd like to share with you 2 cases which I experienced. This is a 70-year-old retired taxi driver with non-ischemic cardiomyopathy. Probably like 6 years ago, he was treated. He was diagnosed as a heart failure, non-ischemic cardiomyopathy, and a primary prevention ICD was implanted. But his EF didn't improve, and he started having a VT. And amiodarone was started and increased, escalated therapy. So as a result of the amiodarone, patient became pacer independent. It's a single chamber device. So he didn't have to upgrade to CRT device at this point. But after the CRT upgrade, he started having a lot of shocks and failed endocardial ablation twice at one hospital. So caring physician who has been seeing this patient long years talked to the patient. He recommended supportive care without the generator change. So one of his fellow felt that's ridiculous, and he talked to the patient, and patient self-referred to our hospital. And his pain test score was 16, so that's relatively high. So after he came, he was on sedation and was still having a lidocaine. What we add was stellate ganglion phototherapy for this patient, but it didn't slow down, and amiodarone and a beta blocker. So took him to the lab once his condition stabilized. So 3 VT was inducible, mainly coming from inferior wall. One is more apical, the other 2 is coming from basal area. This is epicardial mapping. Since he failed twice from endocardial, we did epicardial ablation. So isochronal late activation mapping shows conduction slowing area as the apical inferior wall, and the epicardial voltage shows very large low voltage area. So we inserted the HD grid. This is just one HD grid in epicardial space. Had a lot of delayed potential. So we thought, well, probably his substrate is here. So he developed the VT, and lucky enough, the VT was relatively stable with no epinephrine as a support. So we did map the partial, his VT reentry circuit, and it looks like probably this is the isthmus area, so we entrain, and entrainment shows this site being the central portion of the isthmus. So we ablated there and a VT terminate. And at this site, we also tried to do entrainment again, and the VT terminated without the global capture. And after the termination, this is like a pace map and a very identical CHRS following this stem, long stem to CHRS interval. So he was rehab and discharged home, and now he enjoys life with traveling. He loves traveling. So no VT recurrence over 1.5 years. But I think when you look back, there are a couple of points we shouldn't have done, or probably did better if we move forward instead of escalating amiodarone therapy. If we go a little bit early phase to the VT ablation, probably the patient didn't have to go through all this procedure. Instead of repeating failed endocardial ablation, he could have done epicardial ablation a little bit earlier phase. So I think question is anti-arrhythmic drugs versus ablation for ICD patient. Briefly, I'm going to just zip through the 2 studies. One is by John Saab, Vanish from Canada, and Survive VT. So the Survive VT is a prospective randomized trial that includes ischemic cardiomyopathy and one-to-one randomization to substrate ablation, substrate-based ablation, and VT induction was not required versus anti-arrhythmic therapy. So primary endpoint occurred 28% in ablation group and 46% in anti-arrhythmic drug group. Mainly, this ablation effect was driven by less severe treatment-related complication. As you can see here, it was almost 30% for the anti-arrhythmic drugs, and it was only 10% for the ablation group. Sorry for the busy slide, but for the anti-arrhythmic drug group, there was 23 events, and 11 patients required catheter ablation for under-detection slow VT because of this amiodarone therapy. So this is the Vanish study, as all of us are aware. So comparing ablation group versus escalated therapy group, which we often use, like the previous patient, and primary endpoint of composite death VT storm of appropriate ICD shock after 30 days of treatment. So if you compare the primary outcome, ablation escalated therapy, main difference was driven by the reduction of the VT storm and ICD shocks. The ablation did better. And this is the primary outcome. If a patient was on amiodarone and still having a VT, ablation did better compared to escalated anti-arrhythmic therapy. But if the patient was not on amiodarone, basically the effect was similar. But I think I repeat again, for the anti-arrhythmic drug group, there are so many adverse events like related with anti-arrhythmics. I think we count on amiodarone too much, and also like a beta blocker. We increase it and it become bradycardic, and some people just develop a very slow, undetected VT, which causes heart failure. But in Asia, we have more frequent non-ischemic cardiomyopathy compared to ischemic. So Paul's SCD, Roderick Tan and our group, also the groups in Japan and China, got together and did a randomized study comparing the patient with ICD indication, operative catheter ablation. This study included 42 ischemic patients and 39 non-ischemic and 42 ARVC. Again, we saw reduced VT recurrence in ablation group, but similar cardiovascular hospitalization and similar deaths. So I'm going to just show you the second case. This is 59-year-old male. He's a retired sumo wrestler, but he was quite strong when he was in the sumo wrestling. He was very strong. It's hard to imagine him after like 10 years of the retirement. He was diagnosed as dilated phase of hypertrophic cardiomyopathy, treatment with medication, and had a multiple AF-AT ablation, and his EF became low, 25%. And one event of VT, his physician gave him CRT back in 2017. And he started having a lot of ICD shocks, sometimes three times in a month, and refractory to anti-arrhythmic agent. A lot of amiodarone because he's big. And he developed a PTSD, and I was shocked to meet him in a very depressed mode. He was really fighter, and ICD shock changed him totally. So this is his ECG. VT has an inferior axis and a little bit like right bundloid. And this is what we did. So we inserted the 2 French catheter into the AIV, and we recorded, during the sinus rhythm, we recorded 2 double potentials, the 2 split potentials. And during the LV epicardial pacing and endocardial pacing, we had identical split potential. Sorry. So this is a substrate map. We did an epicardial mapping. He did have a low voltage area along the AIV, probably some related with the fat tissue. And the tip which recorded the split potential was here, as you can see here, this area. So we did a burst pacing from that and induced the VT very easily. So what's happening seems to be like if you have the delayed SP1 to SP2, if it is like become like 120, the VT started. And during the VT, this interval remained as 120. And if you have like a burst a little bit on a shorter cycle length, this interval is a little bit longer and blocks and no VT inducible. So we decided this 2 potential is a critical part of this VT isthmus. So we decided to target at that area. Before we do that, we want to confirm this area is being in a reentry circuit, we tried to entrain, and it again terminated without the global capture at this site. So ablation site, I know it's very close to the coronary artery, but we did have a very similar timing of the split potential. We ablated there with a 25 watts with the 30 seconds. And a VT terminated immediately. So we targeted this slow, split potential, and with the ablation, this split potential went away, and nothing was inducible. But his mental status, as we had a very nice session with Dr. Raji, it was really disaster. So before he went home, he required a lot of rehab and psychological consult, and we decided to do remote monitoring at our hospital and also the family education. And also upon discharge, we used, this is like this is a line, I don't know if you have it here, it's like a WhatsApp, you connect with a patient. So even during the night, when he feels like a shock, he contacts us, and when he feels very uncomfortable, very sad, he gives us a message. Doing this over 6 months, he gradually became to be very confident since he hasn't had any shocks. So I think, again, before I conclude my talk, the study, prospective cohort study, evaluate the patient with multiple etiology, ischemic and non-ischemic cardiomyopathy. So what he concluded was, if you take a look, based on the etiology, ischemic patient, ablation suppressed any kind of VT recurrence, and ICD shock recurrence was reduced. But if you take a look of non-ischemic, I think a non-ischemic patient has a little bit more complex substrate, intramural, epicardial, and probably more difficult to map and difficult to reach. So non-ischemic cardiomyopathy, there was no statistical significant difference in rate of VT recurrence between ablation versus non-ablation group. So I'd like to, before I conclude, this nice slide was given by Dr. Bill Stevenson. It's really nicely summarized the progress and achievement of the ablation therapy. Starting from DC ablation, we moved on to radio frequency and a lot of like contact catheter and irrigation catheter and a needle catheter. And based on these like a multi-center randomized study, we have more information and we have more guidance. So with that, I'd like to summarize my talk. Catheter ablation can be the first-line therapy for ventricular tachycardia associated with structural heart disease. But right timing and probably the candidate, maybe the etiology of the heart, should be further investigated. The harm of waiting too long before catheter ablation should be noted. An ongoing VANISH2 trial, hopefully the result will come out. That is going to be answer our question. Thank you very much again.
Okay, any questions, comments?
Kyoko, thank you. That was lovely.
Thank you.
I have a question that also relates to Alexios's talk. You showed a beautiful case where you had mappable VT. And I can't help wonder how much of that is actually facilitated by the amiodarone. You know, when you can see the whole diastolic pathway, it probably means it's mostly endocardial or on the surface that you're mapping anyway. You have access to it, so you're more likely to be successful, and you're more likely to be able to see it if it's slow and mappable. You're not just doing sinus rhythm substrate or paced rhythm substrate. So I wonder how much do you think amiodarone is actually helping, as opposed to, you know, pickling our patients till they're purple? How do you weigh that in?
I think the amiodarone slowdown, you know, probably it allows us to map. But I don't want to risk the patient. If the patient is younger, I don't want to keep him a long time. And especially like based on the VANISH2 trial and the other trial, I don't want to escalate the amiodarone therapy. So maybe initial step is, if it is non-ischemic, put the patient on an amiodarone, probably 100. If he recurs, I would rather take him to the ablation. Amiodarone helps to map, and I think the beauty of the catheter ablation, I know that there's a lot of like a substrate-based, not induced, like a pace-map-based ablation, but seeing the like a diastolic pathway and also using the entrainment mapping, you can kind of pinpoint where your crucial point is, and you can minimize the ablation point. So I think that's the beauty of it.
John?
Very nice talk, Kyoko.
Thank you.
I have a question, not exactly on ablation, but on mapping. What is the estimation now of the monomorphic VT due to a focal, say, cellular mechanism? I mean, in patients with a scar or with non-ischemic cardiomyopathy, how much of them can have a monomorphic VT purely focal?
Yes.
This is the first question. And the second one is, what is your experience of endocardial mapping using unipolar voltage EGM to predict the scar or a low voltage on the epicardium?
Thank you. To answer the first question, I think focal tachycardia do exist, but I think probably the proportion is for non-ischemic cardiomyopathy. I would say probably 15% or less. And also, even though coming from one focal point, I usually like to do an entrainment if it is possible, because one, I want to see if it is micro reentry or not. I mean, you can do the same treatment, but I still like to see the mechanism. And for your second part, endocardial unipolar mapping, if I don't see no substrate on the bipolar, with a kind of disparate feeling, I usually try to change to unipolar, but it usually give you kind of broad area for the low voltage. At that point, I may do an epicardial ablation, or sometimes if the time is like running late, I probably do a 2 French catheter into the vein to see if there is any suggestion for the epicardial substrate.
What degree of confidence we can have by mapping endo to be sure there is nothing AP? You know what I mean? If we first do endocardial mapping, if the voltage is perfectly normal, more than 8.3 millivolt or something like that, can we be sure there is nothing AP? Do we have the answer on that?
Yeah, I think it's very difficult. And it happens if the patient failed, say, once. Sometimes we decided to go to the other chamber. It could be like if it is septum from right ventricle, left ventricle septum or epicardium, but sometimes we don't have any answer, even though you go to epi and both side mapping, both side looks perfect, and with a unipolar mapping, probably you see something. So if that is the case, I have to assume there must be something intramural, and that's the most difficult situation, I think.
All right, thank you.
Thank you very much.
I would have a comment in the same line as what John said about amiodarone. In some patients where they have maybe not as much, like ventricle is not that dilated, EF is not that low, and they have VT, if we go for, often those patients have very fast VT that are very difficult to map. So what percentage, I think my first part of my question would be, what percentage of your patients with structural heart disease come in without any antiarrhythmic drug have non-mappable too fast VT? And I guess the second part of my question would be, would you consider pre-treating patients with amiodarone to make VT mappable with the intent of stopping it after the ablation, but to facilitate ablation?
Yeah, that's an excellent question, I think. Majority of the patient, because at tertiary center, majority of the patient come with antiarrhythmic agent in my hospital. Unfortunately, with amiodarone and some, still there is a patient, like a patient treated with the sodium channel blocker. But I think you are right. Maybe using IV amio, hoping to stabilize the patient, but I don't think it happens that quite often. Majority of the patients require hemodynamic support. So probably once you induce with a multi-electrode catheter to see what's there, and we quickly terminate the VT and switch to the substrate ablation. But I think just the one event of entrainment or induction and quick ablation and terminate, that would give you the really confirmation you're on the right spot and you can concentrate like doing the lesion. So that's what I usually do. Thank you very much.
All right.
Thank you.
Okay, now as a representative of EHRA, it's a pleasure and an honor for me to introduce Professor Michel Essaguer. Michel was born in Bayonne in France, and he became professor of cardiology in 1994. And he was long time chief of the cardiac pacing and electrophysiology department at the Haute-l'Évêque Cardiology Hospital, which is a part of the Bordeaux University Hospital community. He was elected a member of the French Academy of Sciences in 2010. And in 2011, he founded the LYRIC, a research institute focusing on cardiac electrophysiology and modeling, which brings together more than 150 members from multiple disciplines. Its goal is to improve understanding of the electrical activity of the heart, to reduce suffering and mortality due to heart rhythm disorders. And his investigations, as I can read it here in the Wikipedia, have been the basis for the development of new markers and therapies for atrial and ventricular fibrillation. However, that's the one hand. The other hand, I think, is Michel. I know you as a human being for more than 30 years. First visited you in 1991 in Saint-André, and this was a very nice experience. Tu te souviens, je crois? Oui. And you know, since then I've been so amazed by what you do all these years and what you've done. You know, we started with slow pathway ablation. We looked at these small signals in the old machines then, and then came the IF ablation. And it's now, Laurent told me on the web now, this is around exactly 25 years of your New England paper of atrial fibrillation ablation with the pulmonary vein potentials now. 25 years. Unbelievable. I know this paper was in the New England Journal. This was in your bureau, the ones where you took the veins and looked where it came from, where the activity came from. It was in your in your office.
We call it this schema the Marguerite.
Yeah. And then was, of course, the VF ablation. And, you know, for me, this is the end of my talk. You're a godfather, a mentor, and a good friend. What can I tell you more about that? Thank you.
Thank you, Helmut. Dear friend and dear colleague, it's a pleasure to be here in Canada, where I'm very impressed by the friendly and active EP community that I meet since 2 days. My talk will be about VF substrate, which is a spectrum, in fact, of substrate, which looks to be more complex than, or have a wider spectrum than VT ablation, and will emphasize a problem which is very similar to VT, and which is a problem of sudden cardiac death. We have the treatment, we have the choice with catheter ablation, ICD, of course, and some drugs, but we don't know which patients are the one we have to protect from sudden cardiac death. And this is a big issue we try to solve, at least to progress in the next 10 years. But to progress that, I think we have to do a very sophisticated mapping of VT substrate, of VF substrate, and then maybe we can envisage to do method once we know the different scenario of electrograms, of depolarization, repolarization, and focal activity of each patient, and then we will know how we have to develop the method to identify these different subsets. VF is very interesting because it is the substrate responsible for VF in the younger part of the spectrum. And most of the patients with below 40 years, when they have sudden cardiac death, it's not a VT, it's a VF. And the substrate of VF is discrete, is smaller, and smaller than VT. It's also organized in a cluster of activities, not scattered everywhere. It's something relatively localized, and this is a good point, but it's still less predictable than VT because it's smaller, and sometimes because it's not transmural. And there is a variety of VF substrate to investigate, multiple substrates that we will try to develop now. We talk just a bit of VF with structurally normal heart here, and a bit also of structural heart disease. Outlines. First, we talk about focal triggers. In fact, a group of patients with sudden cardiac death and VF died mainly because of focal things, because of some cells that are very turbulent, and this is enough to kill a person. And then we will see VF in structural heart disease and VF with structural normal heart. And sorry, how can I go back? Well, anyway. Okay, first, the group of VF with a dominant role, of triggers. In patients without structural heart disease, Purkinje system is clearly, I would say, 90% of the initiator of VF. But we also have a patient with RVOT, LVOT, and everybody has seen that, and it's also published in the literature. But the big fish is the Purkinje system. And in patients without structural heart disease, the most significant role of triggers is in a subset of idiopathic VF. In the Casper group in Canada, the incidence reported last year was 6.7%. We have reported 22%, but we don't know exactly, because we probably miss a significant number of these short couple ectopy. And this is one thing to do before we try to develop a specific method to detect this group of patients. Purkinje also is very frequently involved in early repolarization. Most of these initiations we have in early repo were from that. MEPPC, multimorphic EPPC, linked with SCN5A mutation. CPVT, when we have mapped 2 or 3 CPVT, half of the ectopy were from the Purkinje, half was from myocardium, long QT, etc. And in short QT, the 2 patients we have seen were also from Purkinje. Anyway, now there is an important group of the role of Purkinje in these patients without structural heart disease. And something important is when we have a patient with a storm like that, for example, we have to map that. But we don't have to look only at the ICD. This is an information, but make all the effort to detect and identify on 12 lead. When we have a 12 lead of the ectopy, we can work, even in ablation. But if we have a single lead, it's not enough. In structural heart disease, most of these important role of triggers are in post-MI. This storm happening 2 or 3 weeks after myocardial infarction or after PTCA. And you see in the schema here, the big infarct in this patient, anteroseptal here. And at the border of the scar, we have in 80% the triggers are there in the borderline, sometimes inside the infarct. They are island of Purkinje activity surviving within the ischemic heart disease. And there is different paper, notably by Kumatsu, showing that the high success rate of ablation inside, using that. And there is also a medication capable to control the trigger in idiopathic VF or the trigger in ischemic heart disease, which is the quinidine. Yeah. Now, this is this group of patients with spontaneous ectopy. What is special to the short couple Purkinje ectopy is completely random. This is a crazy disease where you can have a storm for 2 or 3 days, and then it is disappear. And we have sometimes a patient with a single episode in a life of 50 years, and sometimes the next month is come back. And probably there is a sort of threshold within the activity, the complex calcium handling, below which there is nothing, and above there is that. And we don't know exactly how to evaluate the threshold in an individual patient, but this is really a crucial clinical issue, is how can we predict this patient with sudden cardiac death. Now we work on a series of 500, more than 500 idiopathic VF that we follow up since 20 years. And the incidence of this Purkinje ectopy seems to be much higher than what we were thinking before. They have narrow QRS when it comes from the left Purkinje, and relatively wide when it comes from the right Purkinje. And you see here, we have a Purkinje ahead of the QRS, but often in the left side, it's easy to identify what we call also fascicular VT. The clinical issue is a random, unpredictable occurrence, and how can we identify this patient? We don't know if we have marker in sinus rhythm. Just for the anecdote, when you see on the top this calcium wave in animals or in optical mapping, in fact, before we see the ectopy in optical mapping, we see clearly a lot of cells. They have some wave, but the number of cells with waves, the amplitude of the wave has not reached the threshold where you get the clinical ectopy. I mean, the cells are already abnormal. They are active, but they are below the radar. I don't know if one day we can imagine that we can have a vulnerable Purkinje cells based on some optical or some identification of this. The second method is genetic. In our group, short COP Purkinje-related sudden cardiac death, we have a 24% incidence of familial history. Obviously, there is something here. We have 2 sisters, we have a twin, we have a mother, father, mother, boy, etc., etc. And what we have done in the past is to try to explore this patient. There is probably a group of polygenic disease with the common denominator is to act on the Purkinje, on the calcium handling. But probably something like the SCN5A in the Brugada. There is a satellite SCN5A gene that can be as active as the SCN5A, and I suppose there is something similar. And this is typically work to do in a collaborative international study to try to solve how many of these genes can be a target then for prediction. And the next thing can be the provocative test. And we have done some work on that, try to excite the activity, and we have used what we have. That means ajmalin, catecholamine, and what we have. And this is the work. You see at the top a patient with spontaneous ectopy here. In this way, and this patient has spontaneous ectopy, idiopathic VF, and when we come to the hospital, he had nothing. Donc, we do ajmalin testing here, and we reproduce that. It was on-off. You do a second ajmalin, it will be on-off, and it's exactly the same morphology. You see a second example here, and in this lady here, it was only isoprenaline that can reproduce the short couple ectopy. Donc, we have done 52 patients with documented short couple Purkinje ectopy, and using pharmacological testing, we can reproduce in nearly half of them, we can reproduce that. Donc this is interesting because I believe the specificity of this finding is possibly higher than the Brugada syndrome. I mean, when we have a short couple, we have an arrhythmia induced by this type of drugs. And this is one interesting thing to do when we have a patient with unexplained syncope, for example. At the bottom, this was the initial paper. You see the reproducibility of the testing years apart. It was 2016, 2020, etc. You see we have 9 years sometimes testing apart, and we have exactly the same response. That means you inject the drug, and we have a sort of biological pathway which is individual to this patient. We didn't find any mutation in SCN5A or RIR2. But this is interesting. When the test is positive, we can guess that this patient is vulnerable to this type of arrhythmia. Now, when we have the chance to map a patient with a catheter in the endocardium, and and you see here we have a triplet of ectopy. The Purkinje we see at the first beat, but when we see 2 or 3 beats, is often we often have the presence of Purkinje activity in the second or third beat. You see here is more impressive here. We have several beats, and each of them, for the first 5 or 6, are preceded. It's not easy to get that in the context even of ablation. Donc I don't know how much of these patients with polymorphic VT have not 1, but 2, 3, or all the polymorphic VT preceded by Purkinje. But probably when we map the first one, we have never seen activity spanning the space from the last sinus to the first ectopy. Donc we are nearly sure the first one is a focal activity, triggered activity. But when we see that, probably the second one, third one, fourth ones are re-entry in the very complex network. It starts from a focal, and then it will turn, it will meander with the network. So this is a good point, because even if we miss exactly the focus, but if we prune, we ablate around, we have a good chance to avoid the second, third one, which is, of course, the most worrying part of the disease. The treatment. Quinidine is clearly the best. A beta blocker is clearly the worst. And then flecaine can work, amiodarone can work in some situations. The group of Viskin and Belacen have shown that it works in idiopathic VF, and it also works in structural heart disease. Most of these ectopy are polymorphic. That means when we resave a patient with a monomorphic PVC and ablation, we do for 1 or 2 days a lot of recording, and nearly always we have 2 or 3 morphology. When the morphology has a family pattern, say they look like the same, okay, we go there. We will go, and because we know we will ablate the earliest, and we will ablate the small area. But sometimes we have left posterior fascicle, left anterior fascicle, intermediate, right ventricle, oof. And in that case, it's a bit risky for the patient. It's a bit complex, we are not sure, and we will try the quinidine first. Well, it's a way we are working. The method we have seen that is, you see, we have a target on, sorry, I don't see well here. Yeah. You see here, we have the Purkinje here, and then within a few seconds it disappears. And the secret of the method is clearly to expand around the area. Even when we have an immediate result, we will expand just to cut what is around. And the success reported by Knecht here or by Komatsu here are really clear. You can get 85% success in a long term. Now something. We have a group of 5 patients. These 2 ladies, 46 and 40 years, have a sudden cardiac death, idiopathic VF, MRI, Ashmaline, etc. And everything was negative. At the top, you see the left Purkinje mapping from distal to proximal, and we deliver extra bit at the coupling here or 210. And at 2 10 milliseconds of coupling interval, we see some repetitive Purkinje activity, 1, 2, 3. And then in C, you see 1, 2, 3, 4. And in the literature, there is a paper by the group of Akhtar. They never see more than 1. They said 2. And in our experience of mapping the left Purkinje here with decapolar, we see 1 or 2. It's like a VNRT. 1 is okay, but 2 or 3 is probably the beginning of something. This lady has nothing else that this repetitive activity, and in fact, after C, we have D, and D was a polymorphic VT Purkinje related, giving VF. We have done 2 or 3 times. It was always a sequence, even when we pace from another part. So we had to see 2, 3, 4 Purkinje polymorphic VT, and then we have VF. And below, this is another lady, 40 years, and we see a longer episode where we have interval of 174, 170, 160, where it was always like that. We had a long episode of polymorphic VT with a Purkinje. When the Purkinje stopped here, 158, the VF stopped. When it prolonged, we have a VF, and we have a 5 patient, 4 female, which is unusual, and I'm sure there is a group of patients with idiopathic VF who has a Purkinje inducible by programmed stimulation. That means if you do not put a catheter in the left side, which is not so aggressive, we may miss that. So probably there is a specific disease here. But it's interesting because it was so repetitive that we guess that this was the reason. So in that case, it's not excitability, it's not calcium-dependent abnormality, it's something in the conduction, something in the connexin, in the SCN5A, something we still don't know. So, just to mean, the more we do in terms of phenotyping, and the more we will know what is this type of disease. Thank you. Now, VF in structural heart disease. We have published a work last year in European Heart Journal, and it was 8 years' work. It was very long to get all these patients. We had 54 patients, 15 ischemic, 12 dilated, 8 hypertrophic, and 19 brugada, and they had only VF. So we map these patients because they have EVF and come most of them for ablation. This is first the induction of VF, and you see clearly we have the organized VF part, which lasts usually 4 or 5 seconds. Then it disorganizes. And we have mapped specifically the initiation here. And we have mapped using the ECGI system, which was the only one we had at this time and still now, to see what are the drivers. We don't look at all the rotor or spiral activity, we just look at the big spot. The big spot here in red, and 2 or 3 spots. In that case, we have something in the septum, we have something in the right ventricle, and we just look at that. We also do endocardial mapping to see how much of these drivers are preceded by Purkinje. So this was a mapping of epicardial part and Purkinje part using common method of mapping. And structural heart disease, looking at the fragmentation, voltage, and scar mapping using MRI. The initial result was something which is known from the experimental data, but it's interesting because now we are dealing with a patient. The initial 2 seconds, the initial exactly from 0 to 4 seconds of VF are by far the most rapid acceleration of the VF compared to all the VF time. And this is something that is seen in animals. That means once the star is start here, it will accelerate very quickly at the first second, and then we see a slowing down, which is related probably at shortening of APD and different mechanism of restitution. Now, in some patients on the right side, We have a group in green where the patient had a VF induced, but the VF will spontaneously come back to sinus rhythm. And in the same patient, we had some induction that lead to sustained VT. Donc we can say in some patient, we will have a syncope, and it will stop. In the same patient, when the episode will last, it will die. He will die. So it gives some idea. The curves are clearly different and strongly different. When the curves accelerate first and then have a sort of plateau, we can anticipate 80–85%, it will stop. And then when it's going down, it will go to VF. Donc, it's interesting because maybe we say, okay, if we have a medication, a beta blocker that can also act on that, possibly patient will have a more syncope and less sustained episode. The second lesson here was when we look at the driver, they were every time, I will show you here, this is a ischemic cardiomyopathy. We see the patient from below. This is in IVP. Donc we have a cluster of driver in the inferior left ventricle. And when we look at the mapping using voltage mapping, you see it's border of low voltage part. And in ischemic cardiomyopathy, in dilated cardiomyopathy, 80% of this cluster of driver are linked to fractionated activity. So this is a good point. They are not aware, they are stick to the scar. It's not a surprise, but it's interesting. At the bottom, we have a dilated cardiomyopathy. And during VF here, near the apex, on the epicardial the ECGI system, we have 12 rotation, which is a lot. And when we map with a catheter on this spot, we see a lot of long fractionated electrograms. We don't have any scar on the MRI, but there was a link between the drivers and that. It's like a stone in a river. When there is a river and there is a stone, it will attract this rotational activity. In Brugada, this was something that was known. We have RVOT, we have RVOT driver here. And at this spot, we have a lot of fractionated activity. This was done with Dr. Nademani in Bangkok. We ablate that. The patient was still inducible. And we found then a second cluster of electrogram abnormal in the inferior RV. We have two spots. It's just to say the drivers are linked to substrate, and the substrate is a fractionated activity. It's why the method of ablating the VF substrate, the myocardial, is close to what is done in VT ablation. Now, the things, when we look at the ECGI, when we look at the beginning of the organized VF here, we have clearly a cluster. We see clearly cluster of drivers. And then after 3, 4, 5 seconds, we see 2 or 3 more, and then at one point they are everywhere. Look, it seems that at the beginning is the rotational activity will increase. At one point, then it will become three-dimensional and complex. But the first part gives a lot of information on the substrate itself. Now, another thing which was an interesting lesson. You remember the idiopathic VF with Purkinje inducible. And when we do that in dilated and hypertrophic cardiomyopathy, we have 35 of the patient where we get one-to-one Purkinje activity at the beginning of VF. I think this is something important. Most of the induction of this Purkinje-related VF are from the left ventricle. If we do apex RV induction, we see nothing. When we do from the LV, we create this activity, and it's reproducible. And the activity we record in the group of patients in dilated or hypertrophic cardiomyopathy was 3 seconds of the VF. 3 seconds of VF is 15 bits. It's a lot. There is most of the organized VF are related to the Purkinje in a group of patients with cardiomyopathy. And this is an example. You see the group, a patient with, he's 29 years, hypertrophic cardiomyopathy, septum 27 millimeter, 7 VF on ICD, no ectopy. This is induction with S2, S3 from the left ventricle. When you see that, there is nothing specific. It's organized, okay. If you don't have any catheter, you will do a cardioversion here. If you have a catheter on the his, you see 1, 2, 3, 4, 5, 6. With a multi-electrode catheter, there is no ambiguity, because even if you have some fractionated activity, the next bipole will capture the Purkinje, and it's much easier to see. We do a second induction in this patient. We have the same thing, despite induction from another part of the LV. And this is the continuation of VF, where we have, you see, we guess what is here, shock. We still have the Purkinje, shock here, and come back to sinus. This patient has been ablated 8 minutes in the left anterior distal, 12 minutes in the distal. It was non-inducible, and we have a 5 years follow-up without nothing. So we are confident it was the only ablation we did in this patient. So this was interesting. Probably the Purkinje in VF is involved in a significant group of these patients, particularly cardiomyopathy. The second case, 63 years, hypertrophic cardiomyopathy, 5 VF on ICD, no ectopy. And look at the induction. The induction is 250, 280 milliseconds of S2, S3, so it's not so short. And we have a VF which looks like a polymorphic VT for a long time before it disorganized here. And in this case, we had not 9, but we have 25 beats preceded by that. So everything was Purkinje-related activity before it moved like that. So in this patient, we are nearly sure that the initial 5 seconds are just Purkinje activity. It will accelerate and finally disintegrate the ventricle. We did selective Purkinje network ablation, and we have, again, non-inducibility and a good outcome. Other cases have been shown by UPenn and a group of that. Donc, the more you will do, the more you will find this type of patient, and it's not very complex to leave a decapolar. Donc, now the result of ablation have been published. Just to say that the myocardial substrate has been electrogram fractionated, have been ablated in 3/4 of the patient. Where we had complex electrograms in the scar is ablated. But we also ablate the triggers. We also ablate the Purkinje when we have it. So it's a sort of multifaceted ablation. But in, say, 1/4, there is no substrate ablation. It's only substrate or trigger ablation. And in the other one, it's a mix of that. It's very similar to VT, except that we add the Purkinje and we add the trigger. And the results are there. The patient had a 10 median of 7 VF before. We have follow-up 5 years after, and we have a 0 median of follow-up. The results are detailed in the European Heart Journal. There is no trick. It's simply as a method of ablation fractionated activity and the method of ablating the Purkinje when he's involved in a specific patient. I have 3 minutes or more? Okay. Now, now, well, it's funny, huh? There is a lot of ECG, huh? It's not. This is to show we also have patients who died, and we died after sudden cardiac death, and we have the opportunity to do a mapping, optical mapping, with the agreement of the family. Just to show 2 cases. The patient is 15, Pierre has 15 years, probably he has a Brugada syndrome. We know because we found the SCN5A mutation. But when he died after playing rugby, he died 1 hour later. This is the heart after 2 weeks in reanimation and the brain damage. The heart is nice. I mean, there is no fatty tissue. that allow optical mapping. And this is the mapping from exactly from this region here. This is the optical mapping here. We are pacing from the apex. And you see the isochrone. And then there is a clustering of isochrone in the RVOT here. And this is in sinus. That means these patients are clearly in abnormal conduction. And you see it's, again, something, there is a cluster here. The disease is not 3, 4, 5 points. It's a cluster. And this is a good news, because there is probably also, this is a substrate, need a critical mass. And in this case, when we deliver 1 extra bit, we had a re-entry starting at the RVOT. So we found probably what is a Brugada, the case has been published. In that case, it illustrates a localized region of deep, abnormal slower conduction responsible for sudden cardiac death. In the bottom, it's a young girl with early bipolarization. She has been transplanted. We could not control the story without quinidine with experimental drugs. And this is the optical mapping of the LV endocardium. And you see we have a cluster, we have only an island in red of abnormal action potential. The disease looks to be everywhere, but in fact, there is a cluster here, and you see the ITO here, which is the dip, which is abnormal. We have characterized all that, and for the story, in Andelevich, the abnormality was supposed to be the epicardium. In this patient and in her sister, who had the same thing, the abnormality is the ITO endocardial, which is a very small form of that. Now, I will insist for in idiopathic VF on the importance of doing all the investigation, and probably pharmacological testing. I believe that ajmaline is probably more adequate than procainamide, but I know that Canada has an issue for that. But probably there is a loss of chance, I think, for the patient when we inject some procainamide, because we have done that in the past. Procainamide was negative, ajmaline was obviously a Brugada syndrome. And then when we have mapped the patient, he had abnormal RVOT. Donc we have a lower sensitivity with procainamide. And the second thing that we believe is important is a catecholamine injection by isuprel and adrenaline for long QT, because we have a significant number of patients with exercise test which is normal, while isuprel is explosive, if I can say like that, polymorphic VT from the RV, and we found an abnormality in the RV, possibly IRVD, and things. Without doing that, this type of pharmacological testing, probably we underestimate some etiology of this ischemic idiopathic VF. And what we do for this patient, we do a mapping using the Purkinje mapping. We also do endo and epicardial mapping, and it's where we found a significant number of patients with microstructural abnormality. I will show you 2 or 3 examples quickly. Yeah, this is just one example of early bipolarization. It was a work from Tsukuba, Bangkok, and Bordeaux. You see with the same phenotype that you can see in 2-3 VF. Within the same phenotype, some patients have a normal depolarization here at the top, and at the timing of the J wave, there is no depolarization wave. It's just a hump of unipolar. They are the true early repolarization. And some patients have the same J wave. When you map there, you see abnormal voltage, you see fractionated electrograms, you see here, and it's exactly like a Brugada in the inferior part. So it's 2 completely different diseases. If we don't map, we don't have the answer. Now we can guess some hint of early bipolarization because it's much more flexible, and when there is a pause, it increases, which is not expected for a depolarization abnormality. And now quickly in the idiopathic VF, what we reported 2 years ago is that 22% of these idiopathic VF have the Purkinje short couple ectopy or Purkinje inducibility, and it seems that we have 67% with this type of abnormality. We map the epicardium, and we have an island here of abnormal activity. And when in this patient we induce VF, the driver seems to be stuck on that. Donc we believe that a significant part of idiopathic VF are cardiomyopathy, which is just below the resolution of what we have using MRI. One example here. A lady at 23 years, the late potential doesn't exist on signal averaging, and you see in the white, you see here, we have clearly the electrograms that Alexios and Kyoko has shown, which is completely abnormal. And there is no abnormality in terms of genetics of cardiomyopathy of ARVD, but it looks like the same thing. And the surface of this type of abnormality in idiopathic VF is significant. It's 14 centimeters square, 5%. And this is another patient from Canada. He was a hockey player. And the MRI, etc., was normal, no genetic mutation. And epicardial mapping show, you see at the bottom here in the inferior LV, you see this small island of activity late here. And in the lateral part, we have still some fractionated. We have ablated. It was difficult to ablate that because there was a coronary artery that. And I believe the patient is still in good shape. And then one before the conclusion. In DPP6 mutation, you know, it's an endemic mutation in Netherlands, and it was believed to be selectively increased in the ITO. So it was described as a mutation that affects the Purkinje ITO and responsible for short couple ectopy that you see on the left side. In this patient, we also map the epicardium, and you see on the right side, there was a huge abnormality in a big part of the right ventricle. That means despite a mutation that we believe being relatively limited, we have a much wider type of abnormality. I mean the genotyping plus phenotyping will be probably something that will help us to decipher all this disease. I will just mention that this is if we consider that idiopathic VF has on the left side a disease from the Purkinje, where the tissue is healthy. If we consider that another part of idiopathic are patients with abnormal myocardium here, where the VF is in abnormal tissue, we can expect that when they will have a recurrence of VF, 1 year or 20 years later, this will impact on that. So this is the work underway, which is nearly finished. And I will show you one example at the bottom. This man, in 22 years before, he was 22 years. He was driving a car, and he had a VF. We found nothing, no treatment. 19 years later, he's here. He had a VF. You see, no ectopy, boom, VF, shock, come back. When we analyze the sinus rhythm before, the trigger coupling, and the VF cycle length, we have 95% sure it's a Purkinje activity. This is terrible, but we have a sort of remake of what happened 20 years before. And there is no metabolism, no traumatic injury to the heart that allow to have a new type of phenotypic marker to help again to decipher all these patients. Thank you very much for your invitation.
We've got Helmut back up. Any questions from the panel first? Yes.
Michelle, wonderful talk. I really enjoyed it. Just wondering for the deep phenotyping, is there any use of a cardiac biopsy? You mentioned about the abnormal myocardial.
Yeah, I mean, I think if we do a biopsy, it will be ideal to do that where we have the abnormal electrograms. I mean, in the group of the multicenter where we have it, there were biopsy, particularly in Germany or in Italy, and it was not, it was a blinded location of the biopsy, it was not relevant. I would say if we can do a biopsy where we had the abnormal electrograms, it would be ideal because we would see if we have fatty tissue, if we have inflammation, if we have fibrosis, etc. Voilà. It's not so common. But
yeah, if you could grab the mic there.
Thank you. That was wonderful, and I appreciate all that you've added to our knowledge of electrophysiology of ventricular and atrial arrhythmias. My question is related to genotype phenotype, and I'm wondering if in the arrhythmogenic cardiomyopathies, whether there are any mutation-specific patterns. For instance, is there anything in a DSP cardiomyopathy that behaves electrophysiologically differently from a Titan cardiomyopathy, or is it just that that's the vehicle to create a arrhythmogenic substrate which looks the same in both in terms of the arrhythmia?
Your question is?
The question is there a specific pattern that is genotype specific in terms of the pattern of the arrhythmia?
Yeah. We had a discussion with yesterday in Montreal with a group working on the CASPER registry. I think we have 200 or 300 exomes on that. There is a lot of different mutations. The mutations have been eliminated. I mean the cardiomyopathic, or we have a relatively few. I will say 8%. 8%. Now we have a higher number of VUS that probably, if we can mix the result of VUS and the expected impact on ryanodine, etc., I hope that it can help us to move the VUS from pathogenic to or something like that. What I mean is we have not done a lot of that. We have not done exome, but all these results, as you do for CASPER, deserve to be more deeply genotyped. 8% only of abnormality, and a lot of VUS, where for some of them we are doing some functional study. But we didn't find something which is the same. I will say that when we have this left ventricular abnormality, we have a very few of mutation of VUS. When we look at the RV, we have more. I don't know what is the significance of that. But certainly, we have to work together, geno and the phenotyping.
Merci beaucoup, Michel. I have a question concerning inducibility when you try to ablate. So when you're doing EP study, Julia Tourigny yesterday told us about a new protocol to induce VF in patients with idiopathic VF with long train of stimulation, then a pause, then a short couple PVC. Is that the type of EPS that you use, or you use standard?
Yeah. I think Julia was talking of CHRS, right? That means loss of function of ryanodine. Yeah. I don't know for this disease if this protocol is adequate, just to say that. But it seems to be proper to the CED, the loss of function in ryanodine. Now, the protocol is simply what we do. Apex RV, RVOT, we do only Apex VD and Apex LV, or left side of the septum, 1, 2, 3 extra bit. And we 10 milliampere. What is clear is when we have this inducibility in terms of VF, just to know if you want to induce a VF without any specificity, the result of the group of the cohort is 35%. which is ridiculous, because 100% have a VF, and only 35% are induced in VF, which has no significance. What we look for is if we induce a VT, because a VT will mean a substrate, and if we have a Purkinje preceding each bit of VF. So the protocol is for that. But in early repo or in idiopathic VF, the induction of VF to see if it's inducible has no value, I believe, except this specific protocol.
Just real quick with the LV stimulation, the pictures you showed of the multipolar catheter.
Yeah.
Is it sort of a common position you'll put it in, sort of the low septum out towards the apex, or do you have to map different areas of the ventricle?
No. We consider that if we have the catheter this way vertical, where the distal shows some Purkinje, the proximal and mid too, we will pace from distal and we record all the proximal, and it's relatively stable. And we believe that because it's a left posterior fascicle, if there is something turning, we will have some activity coming there. Because we cannot map all that.
A brief question. First, a reminiscence from 25 years ago when you totally changed my thinking. I was very young. and suddenly atrial fib was a totally different disease. And then you did it again with ventricular fibrillation. And no one else thought it. Anyway, that's my reminiscence. But I wanted to ask you, do you think when you see a lot of ectopy from structural heart disease, from Purkinje network that's nearby, is that independent and coincidence, and you're only seeing them because maybe they have a small old healed myocarditis and the Purkinje ectopy is nearby and therefore able to propagate? Or are they involved, the same etiology, if you like? Did the disease that caused some old scar, did that also injure the Purkinje network?
You mean that if we some Purkinje induced, in that case, can it be ischemic post? You mean cardiac arrest? It can be an option. This is a question.
Yeah, my question is it the coming together of Purkinje ectopy, which many people have from all kinds of places, and some scar? Or does are the scar and the Purkinje ectopy likely from the same disease? Does that make sense?
You talk about idiopathic?
I'm talking about scar-related, whether it's post-infarct, old myocarditis, that 22-year-old with 20, or the young man with 20 years between his VF episodes, where there's not a lot of...
Yeah. I think maybe in some of them, there can be something... a small episode of ischemia. We have maybe 1 or 2 on that, But when we do the protocol, it's 1 month after the cardiac arrest, sometimes 3 months after. I think they are real. I mean, when we have a young guy with ergonovine, no spasm, no coronary artery, I don't think that there is some influence of an ischemic event. What we have seen, now we have this longer follow-up, this man with 20 years later, with a pattern of VF initiation of ICD, which resemble what we know in typically Purkinje. I think it's true. There is more Purkinje than we believe. But possibly some of these patients have no short couple. I mean, it's like the pulmonary veins. Sometimes when he's there, he starts immediately. We need to do all this phenotyping. For some patients, it's hard, but they die. It's not so complex to explain to the patient. We will do a mapping, relatively sophisticated, to understand what they have. And often when we do that, we said we found an abnormality in the RV. The family is happy. The patient is happy because now we understand. And then we said we can also ablate that. But there is a group of investigators in France or even in our group. They said we have not to do that except if we don't have to do an ablation. So there is some physician that prefer to wait for a recurrence to do the protocol For me, when the patient has an extreme event like a sudden death, I think it's ethical to do that to understand. But what I can tell is the patient are happy and the family are happy to have an explanation.
Actually, Helmut, I'm going to, just due to time, I'll give Helmut the last question here. So, sorry.
Thank you. Michel, what is your opinion on quinidine? Why does it work that well? What do you think? Because you said quinidine is the best drug, and beta blockers are the worst drugs for some of these.
Why quinidine is working? I think because there is some, the ITO is more present in Purkinje than in the myocardial cells. Okay. Probably, donc it's because there is an inhibition of ITO. Yeah, but it's true. The mechanism is not so well established. Yeah, but by far it's the best. It's not 100%. I will say it's 80%. But and the issue that everybody knows is the gastrointestinal issue in 30% of these patients. Mais bon.
Well, thank you very much, Michel. Thank you very kindly. I just want to thank everyone for the session. Michel, Kyoko, for coming all the way here. Helmut, next time we'll get you to come here, okay?
Thank you.
And for our local panelists, Isabel and John, thanks very much.
Thank you. Have a nice day.
So it's now time to close the scientific program of our meeting. I would like to thank all the distinguished faculty for have generously shared their expertise and knowledge. Your contribution inspires all of us to push further the boundaries of the EP. Presentation will be available soon on the CHRS website. I would like also to acknowledge the hard work and dedication of the planning committee who helped us putting together that program. So Larry, John, Laurent, David, Jamie, Michael, Leila, and Andrew. With a special mention to Sarah Faubert for all the coordination. I would also thank the organization team from Jamestown, Bobby, Shana, Abab, all of those involved in the AV technician, and the whole team behind the scene. Their meticulous planning and attention to details have ensured a great experience of all participants. Furthermore, I would like to express my gratitude to our sponsors and exhibitors, and in particular our gold sponsors, Abbott, Boston, and Medtronic. We are so grateful for your partnership in making these events possible. You will receive a link for a survey in the next days. Please fill it and give us all your comments and feedback to increase the quality of the meeting next year. And with filling the survey, you receive your certificate of attendance. Perhaps you have seen on the slide during the breaks, 2 events are coming soon. First one, the Lead and Device Management Symposium in 1 month in Calgary, so October 14th. A great occasion to extend your experience in the area. And the other one, the Arrhythmia update in Whistler on February 15 and 16th. Lastly, I would like to thank every one of you for attending the electrifying EP meeting. Your active participation, your thought-provoking questions and engaging discussions have made this meeting truly exceptional. This meeting is not yet done. I hope you will enjoy the afternoon in Banff and the diner that we organized this evening. For that, there's some coffee and snack to go in the exhibit hall. You can grab just before enjoying the mountains. For people registered to the Banff tour, the bus will pick you up at 3:30 at the main entrance at the Banff Center, where you check in. And for dinner, the bus will pick you up at 6:15 and 6:35 p.m. at the same place, with a returning time at 9:15. Don't forget to save the date for next year for another great meeting at Niagara-on-the-Lake on September 13th and 14th. And now I let Laurent speak for the last words.
Thank you, Blandine. So I want to add my voice to yours to thank all those who made this meeting a success. I think it was a success. Even virtually, I could feel it was a success. But I especially want to thank her for driving the show, especially with me checking on her and everything at a distance. So it's not an easy task. So I would like to a hand of applause for all the organizers and especially for Blandine. So I hope you appreciate the meeting and that you'll enjoy some outdoor activities this afternoon, followed by a nice dinner, as Blandine mentioned. See you in person at CCC Vascular in October. Don't forget to attend one of the 14 CHRS organized sessions at the cardiovascular meeting, including our CHRS Spotlight session, and we welcome new EP in Canada. And of course, save the date for our CHRS networking event at HRS. It's going to be on the Friday evening of the meeting. And make sure all of your fellows are registered as CHRS members. It's free, and they will receive the invite to get to those activities. And of course, mark the dates for next year at Niagara-on-the-Lake. So on that, the only obstacle between you and the outdoors, so I'll let you go and enjoy the rest of the stay.